Question 1. A patient's ECG shows a wide QRS complex tachycardia at 180 BPM with no visible P waves. The patient is pulseless. What is the immediate nursing action? A. Administer IV adenosine. B. Begin CPR and prepare for defibrillation. C. Administer IV amiodarone slowly. D. Give oxygen and obtain 12-lead ECG. Answer B. Begin CPR and prepare for defibrillation. Rationale: pulseless ventricular tachycardia requires immediate CPR and defibrillation. Adenosine and amiodarone are used for stable patients. Obtaining a 12-lead is inappropriate in a pulseless emergency. Question 2. An ECG shows progressive PR interval prolongation followed by a dropped QRS complex. What is this rhythm? A. First-degree AV block. B. Mobitz I Wenckebach. C. Mobitz II. D. Complete heart block. Answer B. Mobitz I Wenckebach. Rationale: Mobitz I is characterized by progressively lengthening PR intervals until a QRS is dropped. Mobitz II has constant PR intervals with dropped QRS. Complete heart block has no relationship between P waves and QRS. Question 3. A patient in the telemetry unit shows torsades de pointes. Which electrolyte imbalance is most commonly associated with this arrhythmia? A. Hyperkalemia. B. Hypokalemia. C. Hypomagnesemia. D. Hypercalcemia. Answer C. Hypomagnesemia. Rationale: torsades de pointes is strongly linked with hypomagnesemia and prolonged QT interval. Hypokalemia and hypocalcemia may contribute, but magnesium replacement is key. Question 4. A client with atrial fibrillation has a ventricular rate of 140 BPM and reports dizziness. What is the nurse's priority action? A. Prepare for immediate cardioversion. B. Administer IV beta blocker. C. Encourage the patient to rest. D. Obtain cardiac enzymes. Answer B. Administer IV beta blocker. Rationale: in hemodynamically stable AF with RVR, the priority is to control ventricular rate with beta blockers or calcium channel blockers. Immediate cardioversion is for unstable patients, e.g., hypotension, altered LOC. Question 5. A post-MI patient develops ST elevation with a wide complex ventricular rhythm at 160 BPM. The patient is unresponsive and pulseless. What is the immediate intervention? A. Synchronized cardioversion. B. Defibrillation. C. IV lidocaine. D. Oxygen via non-rebreather mask. Answer B. Defibrillation. Rationale: ventricular fibrillation or pulseless VT requires immediate defibrillation. Synchronized cardioversion is used in unstable tachycardias with a pulse. Question 6. An ECG shows sawtooth flutter waves with a ventricular rate of 150 BPM. The patient is stable. What is the most appropriate nursing intervention? A. Administer IV diltiazem. B. Perform synchronized cardioversion. C. Start CPR immediately. D. Give sublingual nitroglycerin. Answer A. Administer IV diltiazem. Rationale: stable atrial flutter is managed by controlling ventricular rate with medications such as diltiazem or beta blockers. Cardioversion is for unstable cases. CPR is not indicated unless pulseless. Question 7. A telemetry monitor shows complete heart block. Which finding requires immediate nursing action? A. Ventricular rate of 32 BPM with hypotension. B. Atrial rate of 80 BPM with no symptoms. C. Ventricular escape rhythm at 45 BPM and stable BP. D. Occasional premature ventricular contractions. Answer A. Ventricular rate of 32 BPM with hypotension. Rationale: complete heart block with a low ventricular rate and hypotension indicates poor perfusion and requires immediate intervention, often pacing. Other findings may be monitored if the patient is stable. Question 8. A patient's ECG shows fine VF. What is the nurse's immediate priority? A. Check for a pulse. B. Defibrillate immediately. C. Administer IV epinephrine. D. Prepare for synchronized cardioversion. Answer: A. Check for a pulse. Rationale: always verify pulselessness before shocking. If no pulse, defibrillate and follow ACLS protocol. If pulse is present, it may be artifact. Question 9. An elderly patient with chronic AF is prescribed warfarin. The nurse notices the patient's INR is 5.0. What is the nurse's priority action? A. Administer warfarin as ordered. B. Hold warfarin and notify the provider. C. Give vitamin K immediately. D. Schedule next IN or check in 1 week. Answer: B. Hold warfarin and notify the provider. Rationale: INR of 5.0 indicates high bleeding risk. Warfarin should be held and provider notified for possible dose adjustment. Vitamin K is reserved for serious bleeding or very high INR. Question 10. A patient with chest pain develops ST elevation and leads to 3. An AVF. Which cardiac rhythm complication should the nurse monitor for closely? A. Atrial fibrillation. B. Complete heart block. C. Sinus tachycardia. D. Ventricular bigemina. Answer: B. Complete heart block. Rationale: inferior wall MI leads to 3. AVF is associated with AV node involvement, which may lead to complete heart block. Nurses should monitor for bradyarrhythmias and prepare for pacing if needed. Question 11. A wide complex tachycardia at 170 BPM shows AV dissociation with occasional capture and fusion beats. The patient has a pulse but is hypotensive. What is the best immediate intervention? A. Synchronized cardioversion. B. Adenosine rapid IV push. C. Carotid sinus massage. D. IV diltiazem bolus. Answer: A. Synchronized cardioversion. Rationale: presence of AV dissociation with capture/fusion beats confirms ventricular tachycardia. Hypotension equals instability, immediate synchronized cardioversion. Adenosine and AV nodal blockers, diltiazem, risk deterioration and are not first line in unstable VT. Vagal maneuvers are inappropriate in instability. Question 12. An irregularly irregular rhythm with at least 3 distinct P-wave morphologies and a ventricular rate of 110 BPM is observed in a COPD patient. What is the rhythm? A. Atrial fibrillation. B. Multifocal atrial tachycardia. C. Atrial flutter with variable block. D. Junctional tachycardia. Answer: B. Multifocal atrial tachycardia. Rationale: MAT requires greater than or equal to 3 P-wave morphologies, irregular rhythm, and rate greater than 100 BPM, classically in COPD. AF lacks discrete P waves. Atrial flutter shows sawtooth waves. Junctional tachycardia has absent/inverted P waves from the AV junction. Question 13. A young patient with palpitations has a regular narrow complex tachycardia at 190 BPM. During adenosine administration, transient AV block reveals retrograde P waves immediately after QRS. Which mechanism is most likely? A. AV nodal reentrant tachycardia. B. Atrial flutter with 2:1 conduction. C. Orthodromic AV reentrant tachycardia via accessory pathway. D. Sinus tachycardia from hypovolemia. Answer: A. AV nodal reentrant tachycardia. Rationale: adenosine-induced transient AV block unmasking P waves buried in or just after QRS is classic for AV and RT. Orthodromic AVRT often shows retrograde P waves, but adenosine typically terminates both. The timing RP short strongly favors AV and RT. Atrial flutter would show flutter waves. Sinus tachycardia is usually less than 180 and has gradual onset/offset. Question 14. A patient with known Wolff-Parkinson-White presents with a wide complex, very rapid irregular tachycardia after alcohol binge. Which medication should the nurse avoid while preparing for cardioversion if the patient becomes unstable? A. Procainamide. B. Amiodarone. C. Diltiazem. D. Synchronized cardioversion. Answer: C. Diltiazem. Rationale: in AF with WPW, AV nodal blockers, diltiazem, beta blockers, digoxin, adenosine, may accelerate conduction down the accessory pathway VF. Procainamide or cardioversion if unstable is appropriate. Amiodarone is controversial but preferred over AV nodal blockers. Many guidelines favor procainamide. Question 15. Telemetry shows regular flutter waves at 300 per minute with a ventricular rate of 150 BPM. After 6 milligrams adenosine, the ventricular rate briefly slows and flutter waves become obvious, then the tachycardia resumes. What is the next best step for a stable patient? A. Start IV diltiazem for rate control. B. Give atropine 0.5 milligrams IV. C. Immediate unsynchronized defibrillation. D. Administer IV lidocaine. Answer: A. Start IV diltiazem for rate control. Rationale: adenosine can help unmask flutter waves but does not treat atrial flutter. Stable patients require rate control with diltiazem or beta blocker. Atropine increases AV conduction. Defibrillation is for pulseless rhythms. Lidocaine targets ventricular arrhythmias. Question 16. A PACE patient shows intermittent pacing spikes that are not followed by QRS complexes, more frequent during hypoxemia and acidosis. What pacemaker problem is this? A. Oversensing. B. Failure to capture. C. Failure to sense. D. Runaway pacing. Answer: B. Failure to capture. Rationale: a spike without subsequent depolarization indicates failure to capture. Common precipitants are hypoxemia, acidosis, electrolyte derangements, lead displacement, or low output. Oversensing suppresses inappropriate spikes. Failure to sense shows spikes at wrong times. Runaway pacing is obsolete terminology for rapid pacing due to malfunction. Question 17. A patient with prolonged QT develops polymorphic VT. Despite IV magnesium and correction of electrolytes, episodes recur with hypotension. Which temporizing rhythm strategy is preferred? A. Increase amiodarone infusion rate. B. Overdrive transvenous pacing to 90 to 100 BPM. C. Adenosine 12 milligrams IV. D. Synchronize cardioversion once, then observe. Answer: B. Overdrive transvenous pacing to 90 to 100 BPM. Rationale: for recurrent torsades de points refractory to magnesium, increasing the sinus or ventricular rate via overdrive pacing shortens QT and suppresses ectopy. Amiodarone may prolong QT. Adenosine is ineffective. Cardioversion treats episodes, but not recurrence. Question 18. An ECG shows regular wide complex tachycardia at 160 BPM. There is positive concordance of QRS in precordial leads and a northwest axis. Which diagnosis is most likely? A. SVT with aberrancy. B. Ventricular tachycardia. C. Atrial flutter with 1:1 conduction. D. Atrial tachycardia. Answer: B. Ventricular tachycardia. Rationale: precordial concordance and extreme axis deviation northwest strongly favor VT. SVT with aberrancy typically lacks these features. Atrial flutter with 1:1 would be narrow unless pre-existing bundle branch block and would show flutter waves. Question 19. During resuscitation, the monitor shows organized narrow complex electrical activity at 70 BPM, but no palpable pulse and no measurable blood pressure. What is the rhythm and first priority? A. Asystole, give atropine. B. PEA, high quality CPR and epinephrine. C. VT with a pulse, synchronized cardioversion. D. Sinus bradycardia, give dopamine. Answer B. PEA, high-quality CPR and epinephrine. Rationale: pulseless electrical activity equals organized ECG without mechanical pulse. Immediate CPR and epinephrine are indicated while searching for reversible causes, HS and TS. Atropine is not recommended in PEA/asystole. Question 20. A postoperative patient on telemetry shows sudden sinus pauses up to 6 seconds with syncope. Which immediate intervention is most appropriate while awaiting definitive therapy? A. For adenosine bolus. B. Apply transcutaneous pacing and prepare for transvenous pacing. C. Start IV metoprolol. D. Perform Valsalva maneuver. Answer B. Apply transcutaneous pacing and prepare for transvenous pacing. Rationale: symptomatic sinus node dysfunction with long pauses, and syncope requires emergent pacing support. Adenosine and beta blockers worsen bradyarrhythmia. Valsalva is for SVT, not pauses. Question 21. In a wide complex tachycardia at 160 BPM, lead AVR shows an initial dominant R wave, and the QRS onset to nadir in any precordial lead is greater than or equal to 40 milliseconds. What is the most likely diagnosis? A. SVT with aberrancy. B. Ventricular tachycardia. C. Atrial flutter with 1:1 conduction. D. Pre-excited SVT, orthodromic. Answer B. Ventricular tachycardia. Rationale: initial R in AVR and a prolonged initial ventricular activation, VI over VT criteria. Onset to nadir greater than or equal to 40 milliseconds strongly favor VT. SVT with aberrancy typically lacks these VT-specific features. Atrial flutter with 1:1 is usually narrow unless baseline BBB. Pre-excited SVT is usually narrow with delta in sinus, not during tachycardia. Question 22. An irregularly irregular rhythm in AF shows a long RR interval followed by a short RR interval and then a single wide QRS beat. What phenomenon best explains the wide beat? A. Fusion beat from VT. B. Ashman phenomenon. C. Ventricular escape beat. D. Pre-excitation via accessory pathway. Answer B. Ashman phenomenon. Rationale: in AF, a long, short cycle can produce rate-dependent aberrancy, Ashman, causing a single wide beat. Fusion and escape beats occur in different contexts. Pre-excitation causes consistently pre-excited complexes, or irregular very wide tachycardia, not isolated long, short aberrancy. Question 23. Irregular tachycardia at 150 BPM lacks obvious P waves. With gentle carotid massage, the ventricular rate slows, and sawtooth atrial activity becomes apparent in 2-3 AVF. What is the rhythm? A. Avner. B. Atrial flutter with 2:1 conduction. C. Sinus tachycardia. D. Orthodromic AVRT. Answer B. Atrial flutter with 2:1 conduction. Rationale: vagal maneuvers transiently increase AV block, unmasking flutter waves, sawtooth, at 300 per minute with ventricular rate 150, 2:1. AVNRT/AVRT typically terminate or show retrograde P immediately after QRS. Sinus TAT shows clear P before each QRS. Question 24. After PCI for STEMI, a patient develops a regular wide complex rhythm at 70 to 90 BPM without hemodynamic compromise. What is the preferred management? A. IV amiodarone infusion. B. Immediate synchronized cardioversion. C. Observation for accelerated idioventricular rhythm. D. IV lidocaine bolus. Answer C. Observation for accelerated idioventricular rhythm. Rationale: AIVR, reperfusion arrhythmia, is usually benign and self-limited. Avoid suppressing unless unstable. Amiodarone/lidocaine are unnecessary and may depress rate. Cardioversion is not indicated when stable. Question 25. Motion artifact on telemetry mimics course VF in a talking, perfused patient. What is the safest immediate action? A. Deliver unsynchronized shock. B. Check patient, verify pulse, and secure/replace leads. C. Start IV amiodaron. D. Perform synchronized cardioversion. Answer: B. Check patient, verify pulse, and secure/replace leads. Rationale: always assess the patient first. Artifact VF with intact perfusion mandates lead/skin check, not defibrillation. Shocking a perfused patient is dangerous. Drug/cardioversion are inappropriate. Question 26. A hypothermic patient 30 degrees Celsius shows marked sinus bradycardia with J, Osborne, waves, and frequent PVCs. Which intervention best reduces malignant arrhythmia risk? A. Rapid large dose amiodaron. B. Gentle handling and active rewarming. C. Immediate transvenous pacing. D. IV diltiazem. Answer: B. Gentle handling and active rewarming. Rationale: hypothermia predisposes to VT over VF. Priority is controlled rewarming and minimal stimulation. Antiarrhythmics and AV nodal blockers may worsen instability. Pacing is reserved for refractory, symptomatic brady unresponsive to rewarming. Question 27. A pacemaker-dependent patient has prolonged pauses with no pacing spikes during pectoral muscle activity. Normal capture returns when still. What malfunction is most likely, and what is the immediate bedside measure? A. Failure to capture. Give magnesium. B. Failure to sense. Decrease sensitivity. C. Oversensing. Apply magnet to convert to asynchronous pacing. D. Lead fracture. Turn device off. Answer: C. Oversensing. Apply magnet to convert to asynchronous pacing. Rationale: myopotential oversensing inhibits pacing, causing pauses. A magnet typically forces asynchronous pacing, VOO/DO, as a temporizing measure until device reprogramming. Decreasing sensitivity, raising MV, reduces oversensing but requires programming, not a nursing-only step. Question 28. An extremely rapid, irregular wide complex tachycardia with beat-to-beat QRS variation occurs in a hypotensive patient with known WPW. What is the optimal immediate management? A. IV diltiazem. B. Synchronized cardioversion. C. Adenosine 12 mg IVD. IV digoxin. Answer: B. Synchronized cardioversion. Rationale: AF with pre-excitation, WPW, is irregular, very rapid, and wide with varying QRS. Unstable equals immediate synchronized cardioversion. AV nodal blockers, diltiazem, digoxin, adenosine, may accelerate conduction down the pathway VF. Question 29. An ECG in a febrile man shows coved ST elevation with T-wave inversion in V1, V2, and a pseudo-RBBB pattern. He reports nocturnal syncope. Which statement is most accurate? A. Likely benign early repolarization, discharge. B. Brugada pattern, treat fever aggressively and urgent EP evaluation. C. Pericarditis, give NSAIDs and discharge. D. Posterior MI, give thrombolytics immediately. Answer: B. Brugada pattern, treat fever aggressively and urgent EP evaluation. Rationale: type 1 Brugada pattern, coved ST elevation in V1, V2, with syncope is high risk for polymorphic VT over VF. Fever exacerbates. Requires aggressive antipyresis and EP consultation, possible ICD. It is not benign early repol or pericarditis. Posterior MI localizes differently. Question 30. During a narrow complex tachycardia at 170 BPM, adenosine causes transient AV block. Organized atrial activity continues at the same rate with isoelectric intervals between P waves. What is the most likely rhythm and next step for a stable patient? A. AV and RT. Repeat adenosine until termination. B. Atrial tachycardia. Consider beta blocker or calcium channel blocker. C. Orthodromic AVRT. Synchronize cardioversion immediately. D. Sinus tachycardia. IV fluids only. Answer B. Atrial tachycardia. Consider beta blocker or calcium channel blocker. Rationale: if atrial activity persists despite AV block from adenosine, the focus is atrial tachycardia. Manage with rate control or antiarrhythmics if needed. AVNRT/AVRT usually terminate with adenosine. Sinus TACH has visible sinus P waves and a physiological trigger. Question 31. A patient with COPD presents with tachycardia. ECG shows a regular narrow complex rhythm at 160 BPM with visible flutter waves at 300 BPM, best in V1. The ventricular rate abruptly slows after adenosine, unmasking flutter. Why is adenosine diagnostic but not therapeutic in this case? A. Adenosine increases atrial refractoriness. B. Adenosine blocks atrial reentry circuits. C. Adenosine transiently blocks AV conduction without affecting atrial activity. D. Adenosine terminates all supraventricular tachycardias. Answer C. Adenosine transiently blocks AV conduction without affecting atrial activity. Rationale: adenosine acts at the AV node, so it unmasks flutter activity. Atrial continues at 300 BPM. It doesn't terminate atrial flutter, only AVNRT/AVRT dependent on AV nodal conduction. Question 32. A patient with chest pain shows ST elevation in AVR with widespread ST depression elsewhere. Rhythm is sinus at 110. What does this pattern most suggest? A. Acute right ventricular infarct. B. Left main coronary artery or severe 3-vessel ischemia. C. Benign early repolarization. D. Acute pericarditis. Answer B. Left main coronary artery or severe 3-vessel ischemia. Rationale: ST elevation in AVR with global ST depression indicates diffuse subendocardial ischemia, most concerning for LMCA or severe triple vessel disease. Question 33. A stable patient with palpitations shows a narrow complex tachycardia at 180 BPM. The RP interval is long, PR. The P waves are negative in 2, 3, AVF. Which rhythm is most likely? A. AVNRT typical. B. Atrial tachycardia. C. AVRT orthodromic concealed pathway. D. Junctional tachycardia. Answer B. Atrial tachycardia. Rationale: negative P waves in inferior leads with long RP suggests atrial tachycardia from high atrium. AVNRT/AVRT typically have short RP. Junctional tachycardia would show retrograde P after QRS with short RP. Question 34. Telemetry shows a sudden wide complex rhythm at 200 BPM. Fusion beats and capture beats are present. What is the correct interpretation? A. SVT with aberrancy. B. Polymorphic VT. C. Ventricular tachycardia. D. WPW with antidromic conduction. Answer C. Ventricular tachycardia. Rationale: fusion and capture beats are diagnostic for VT. Atrial impulses occasionally conduct through AV node during VT, creating mixed morphology, fusion, or narrow QRS capture. Question 35. A post-cab patient has an irregular wide complex tachycardia with changing axis and morphology. Electrolytes are normal. What is the likely diagnosis? A. Torsades de pointes. B. AF with aberrancy. C. Polymorphic VT without prolonged QT. D. Ventricular fibrillation. Answer C. Polymorphic VT without prolonged QT. Rationale: irregular polymorphic QRS without QT prolongation in post-MI/CAB equals ischemia-related polymorphic VT, not torsades, which requires prolonged QT. Question 36. A telemetry strip shows grouped beating with progressively shorter RR intervals followed by a pause. P waves are regular. What conduction abnormality is most likely? A. Mobitz I Wenckebach. B. Mobitz 2 AV block. C. SA block. D. Atrial fibrillation with pauses. Answer: A. Mobitz I Wenckebach. Rationale: grouped beating with progressively shorter RR intervals than dropped beat equals Wenckebach. Mobitz 2 is sudden drop without lengthening. SA block causes absent P waves. Question 37. In a patient with known WPW, the baseline ECG shows short PR, wide QRS with slurred delta waves. During tachycardia, the QRS is narrow. What conduction pathway is being used? A. Antidromic AVRT. B. Orthodromic AVRT. C. Atrial tachycardia with pre-excitation. D. Sinus tachycardia with aberrancy. Answer: B. Orthodromic AVRT. Rationale: narrow tachycardia in WPW equals conduction down AV node and up accessory pathway, orthodromic. Antidromic produces wide QRS tachycardia. Question 38. A patient presents with palpitations. ECG shows a wide complex tachycardia at 170 BPM. QRS is left bundle branch block morphology with right superior axis. What is most likely? A. VT from left ventricle. B. SVT with pre-existing LBBB. C. Atrial flutter with variable block. D. WPW antidromic tachycardia. Answer: A. VT from left ventricle. Rationale: LBBB morphology plus right superior axis is classic for VT of LV origin. SVT with LBBB usually retains normal axis. Question 39. An elderly patient shows sinus rhythm with prolonged PR and intermittent drop QRS complexes. The drop beats are not preceded by PR prolongation. What is this rhythm and its management implication? A. Mobitz I, usually benign. B. Mobitz 2, high risk, may require pacing. C. Complete heart block, immediate pacing. D. SA exit block, no intervention. Answer: B. Mobitz 2, high risk, may require pacing. Rationale: Mobitz 2 shows sudden drop QRS without progressive PR changes. Risk of progression to complete block pacing indicated. Question 40. An ECG shows sinus rhythm with a delta wave. The patient is given 4 verapamil for rate control in AF and suddenly develops VF. What explains this outcome? A. Verapamil shortened atrial refractoriness. B. Verapamil enhanced accessory pathway conduction bypassing AV node. C. Verapamil prolonged QT causing torsades. D. Verapamil triggered bradyarrhythmia with escape VF. Answer: B. Verapamil enhanced accessory pathway conduction bypassing AV node. Rationale: AV nodal blockers verapamil, diltiazem, digoxin, adenosine are contraindicated in WPW with AF. They block AV node, forcing conduction via accessory pathway, very rapid ventricular response, VF.
If you found this video helpful, don't forget to like, subscribe, and share with your fellow nursing students. Hit the bell icon so you never miss an update. See you in the next one. Happy studying!